మొత్తం అన్ని మినిమైజ్ పైన మినిమైజ్.
Good morning, everyone. Today we will revise the portion on primary healthcare in India, its organization and delivery part. This comes as an important long question and it comes at several points in your Viva. So this is an important topic from the exam point of view and from the general information point of view also. So we will, in class we have covered primary healthcare delivery in the form of history, definition, elements, organization principles, actual delivery and what are the constraints. So we'll quickly look at that. Adoption of primary healthcare in India and globally, it began with the Alma Ata conference where a lot of importance was stressed on primary healthcare and how health for all by 2020 can be achieved only through primary healthcare. So this conference was held in Alma Ata in 1978 and the concept of primary healthcare emerged from this conference. Later on in 1946, not later on, earlier than that, in Bohr Committee report in 1946, just after independence, which was a health survey and development committee. So they also had proposed that primary healthcare was supposed to be the mainstay of healthcare delivery in India if they were to achieve health for all. So, by definition, primary healthcare is essential care which is made universally accessible to all individuals and acceptable to them through their full participation and at a cost that the community and country can afford. These are some of the important milestones that we have seen. In 1979, after the Alma Ata Conference, Government of India became a signatory and they committed to develop primary healthcare in India towards meeting the goals for health for all. In 1980, a year later, National Health Conference was held to formulate the strategies and responsibility for the entire implementation of the primary healthcare machinery was entrusted to the Planning Commission. An expert committee was also appointed. Later, 1 year, this working group they submitted a report on the which came in the form of the National Health Policy that we still uphold. And in 1983, the first National Health Policy was approved. What we read today is the second revision of the National Health Policy. Now, primary healthcare concept, it did not develop overnight. There have been some changing concepts. In Bohr Committee, it was called comprehensive healthcare because it was all inclusive of primary, it was all inclusive of preventive, promotive and curative services, I would say, and rehabilitative services also. And then it was called comprehensive healthcare. The WHO, UNICEF in 1965, they called it basic health services, while in Alma Ata conference in 1978, the term primary healthcare was coined, which basically means the same services as coined by Bohr Committee or by WHO, UNICEF earlier in 1965. So what was this comprehensive healthcare? It was first used in India by Bohr Committee, as I just said earlier, which meant provision of integrated preventive, promotive and curative cure or services from birth right up to the death of an individual. So right from birth up to the geriatric age group, extreme ages, it provided comprehensive services in a defined geographic area. Board committee also suggested that comprehensive healthcare should replace the policy of providing more medical care. So he stressed a lot on the preventive aspects and provision of preventive services rather than providing a cure for diseases once a person gets diseased. So this concept formed the basis of national health planning in India, and it led to the establishment of a wide network of primary health centers and subcenters that we saw a few years back. Of late, under the NRHM, all these services have been upgraded. Then, what do we mean by basic health services? The term which was used by WHO, it was defined as a network of coordinated peripheral and intermediate health units capable of performing effectively a selected group of functions essential to health of an area and assuring the availability of competent professional and auxiliary personnel to perform these functions. So this was basic health services, which was again grounded and the mainstay of these basic health services remained in preventive concepts and in grassroots care rather than higher medical care. So these were basic health services, and then there was primary healthcare approach. So the first approach, that is comprehensive care as well as the basic care, had some shortcomings. They did not talk anything about community participation. They did not talk about intersectoral coordination with the other sectors which are involved in health, like education, like child development, like food and nutrition. So they did not talk about all this. And finally, there was a dissociation from the socio-economic aspects of health. They did not talk much about the epidemiology of health, which revolves around various socio-economic variants. So all shortcomings of both these approaches were taken care of in the primary healthcare approach, and in its definition only you will see that it is a participative thing where people participate for their own health. So this approach came into existence in 1978, and it has all the hallmarks of primary healthcare delivery, which was proposed first by the Board committee. Now it is espoused by the worldwide international agencies and national governments. So almost every country has some form of primary healthcare structure in place for healthcare delivery, including ours. So this is what a PHC looks like. The mainstay I told you of primary healthcare infrastructure is, if you go from bottom up or if you come from top down, it begins at the primary health center, which is the highest healthcare provision facility in the primary healthcare system. Below that, we have subcenters. Below the subcenters, there are village health guides or village health services. Okay, and since there is intersectoral coordination with various other services like ICDS, so we also have the Anganwadi worker who works at the village level in coordination with the ANM and ASHA, which were introduced under the National Health Mission, so Rural Health Mission. So all these functionaries work at the village level. So we shall see quickly what are the attributes and what are the functions of each of these centers. So in primary health care, the basic attributes of primary healthcare are to provide essential healthcare, and by essential healthcare we mean basic essential services, which includes treatment of common ailments, addressing common public health problems like anemia, malnutrition, okay, and endemic diseases. So these are like tuberculosis, upcoming diseases like diabetes. So these are some of the problems which we talk about or which we address under the primary healthcare machinery. Then there is nutrition, there is sanitation, there is safe water supply, which is all taken care of by the intersectoral coordination with other departments under the primary healthcare. Second attribute is it is universally accessible. That means it is accessible or services are reachable to all sections of the population, whether they are poor, whether they are living in the urban slums, whether they are other marginalized populations. And how this is done? This is done through A&M. Okay, so A&M is chosen very carefully. Nowadays we have ASHA also. So these people are chosen very carefully so that they are chosen by the vote of all the members in the villages, and these people have very good access to all sections of the community. They are acceptable to all sections of the community. So ASHA, A&M, they are not supposed to be chosen by top-down approach. Rather, they are to be chosen by the bottom-up approach or by voting process, a democratic process, so that whatever they advise later on, it is acceptable. These people are acceptable in the community, all sections of the community. So there is a very big role of intersectoral coordination also, so that the services reach all the people. And many other programs you see, like Anganwadi worker, village health guides, which are not directly working under the health sector, but they are working under women development, child development. Inter uh, they coordinate along with A&M so that services are delivered efficiently. Then it should be acceptable, that is, people should accept. So that is, to do that, they always promote so many treatments which are culturally acceptable. Advices are always tailor made so that they are culturally acceptable. Services are delivered by persons who are acceptable to the community. Just I told you that ASHA and A&M are chosen by the A&M is not chosen, but of course ASHA is chosen by the voting process. She is a member of the same village which she is expected to serve. So then they deliver sensitive information very privately, and such issues are also discussed in privacy, not in the open, so that these things become more and more acceptable to the people. Then we talk about full participation as an attribute. We have said in the definition itself that the services are delivered for the people, by the people, through their full participation at a cost that the country can afford and community can afford. So full participation means that people have to participate in finding out what their problems are. So these problems are called felt needs, because the community feels that this is a need for them, and the solutions also come mostly from the community. So various social mapping procedures like Venn diagram, chapati diagrams, other social marketing strategies, community leadership, these are some of the concepts which ensure full participation of the community in defining the needs of the community and provision of services. So then I had showed you some pictures. Now let us see what are the elements of primary healthcare. There are basically 8 elements, and you can divide them into preventive, promotive, and curative so that you can remember it better. First is education concerning prevailing health problems and methods of preventing and controlling them. Second is promotion of food supply and proper nutrition, which is again a promotive component. Third is adequate water supply and basic sanitation. Under this, we talk about safe water, sanitary latrines, environmental sanitation, solid and liquid waste management. So this is also a preventive component. Then fourth is maternal child health care, including family planning, which is again a promotive component. Immunization against major infectious diseases is a preventive component. Prevention and control of locally endemic diseases. These diseases included initially malaria, TB, leprosy, filariasis, fluorosis, goiter, gastroenteritis, STD, but now there are many other diseases also, like pneumonia and so many other diseases which have joined the list of locally endemic diseases. So they should be controlled. Dengue has joined the list. So all these diseases must be identified and they must be controlled. So this is also a preventive component. Then when you talk about appropriate treatment of diseases and injuries like fever, red eye, diarrhea, malaria, boils, ringworm viral infections, then it is a treatment component or a curative component, because now you are giving treatment for the diseases, identifying the disease and giving treatment, and provision of essential drugs, which is the final element, also is a curative component, because it involves various logistics around drug delivery. So these are the 8 elements. There are I would say two promotive components, two curative components, and four preventive components. So it should help you to remember total 8, out of which 2 and 2 are promotive and curative, and 4 are preventive components. So here I had listed them for you. Okay, otherwise I had also given you a mnemonic elements, and you can fit all these 8 components in this elements of primary healthcare based on Alma Ata declaration. All right. The next short note is usually on principles of primary healthcare, and the most important principles of primary healthcare are equitable distribution, community participation, intersectoral coordination, and appropriate technology. The focus of all these principles is on primary prevention. So we shall see these principles briefly. Equitable distribution implies that healthcare must be shared equally by all people, irrespective of their ability to pay, and all people, irrespective of whether they reside in urban area or rural area, whether they are rich or they are poor, they must have access to them. Second thing which we talk about under equitable distribution is social injustice, where the problem of health services being mainly concentrated in the major towns and cities is brought up, and inequality of healthcare has been highlighted for people who are living in rural areas, because doctors don't like to go there and settle down and provide 24/7 services. So they are the worst hit people, they are the needy people, and among them also there are some marginalized or vulnerable groups in rural areas, even in the urban slums, where healthcare services are not as easily accessible as the elite population or accessible population. So the PHCs, they aim to readdress this imbalance by shifting the center of gravity from the cities to the rural areas, and bringing the services to people, closer to people's homes, as close as possible. So that is why PHCs are located in the uh, villages, and all people should be able to have access to those PHCs for healthcare. So this is one of the methods how equitable distribution is ensured. Second is community participation. Under this, we talk about universal coverage by primary healthcare, which cannot be achieved by without the involvement of local community. So this is a very important pillar on which the entire delivery of the primary healthcare rests. So there must be continuing effort to secure meaningful involvement of the community, and there are so many community participation methods that I just showed you, like preparing the social map of the community, identifying the needs of the community. Then at further levels, there are micro planning, self-help groups where meetings are held, and then they participate in their identifying and problem solving of their own problems. So second thing is an approach which is used in India is the use of village health guides and trained guides who are selected by the community. They are accessible to the community, they are acceptable to the people, because they have been living there and provided their services since ages. So everybody respects their advice and tries to follow their advice. So these people are selected by the primary healthcare system, and they are trained scientifically to provide evidence based medicine rather than traditional medicine. So that is also one example of community participation, that is training of trained DIs and village health guides under the primary health care. Then, by overcoming the cultural and communication barriers, they provide primary health care in ways that are acceptable to the community. So, this is the basic major advantage which is offered by training of DIs and of village health guides who are residents in that community. By community, I mean village everywhere. Okay, then there is intersectoral coordination. For intersectoral coordination, the declaration of Alma Ata, it states that primary healthcare involves the addition of health sector, all related sectors and aspects of national and community development, and these are some of the sectors that they have listed: agriculture, animal husbandry. Why agriculture? For grains and pulses and staple food. Okay, animal husbandry is for dairy products and other animal products like meat and fish and all these things. Okay, then there is food industry, which provide works towards processed and stored food. Then education, so that people are educated about what are their needs. Housing, public works, communication and other works. So all this requires very strong political will, so that they work together in ensuring health of the citizens of the country. So to achieve such cooperation, countries may have to review their administrative system, reallocate their resources, introduce suitable legislation to ensure that coordination takes place, and values, action, political will. Okay, so intersectoral coordination is very very important, so that holistic health, okay, health all together from all sectors. We go and advise the people that you should drink safe drinking water. What if the safe drinking water is not available? It is not the responsibility of the health sector to provide safe drinking water. They can only advise. Okay, they can only educate the people about the hazards of unsafe water. Water ultimately has to be provided by public works. So intersectoral coordination is required. Now we go and educate, and the people are not able to understand messages. So they should be literate to understand and value and prioritize what message is important for them. So who will take care whether they are literate or not? The education department will take care. So that is how a link is formed between the various sectors. Then finally, appropriate technology, which means technology that is scientifically sound, adaptable to local needs, and acceptable to those from whom it is used, and it can be maintained by the people themselves in keeping with the principle of self-reliance and resources in the community and the country that can be afforded. So appropriate is emphasized here because in some countries, large luxurious hospitals that are totally inappropriate for the local needs are built. And even in our country now, we have so many Apollo, Yashoda, and Care Hospital, and these things are they really meant for the poor? So this is gross inequity and pumping of resources towards building of large organizations which do not tackle day-to-day needs of the poor and marginal population. So these hospitals not only they cater to a segment of the population, they also absorb a major budget, national health budget, and they that's why they are blocking any improvement in the general health services. So that should not happen. We should have appropriate technology at the grassroots level also. For simple services like vaccination, people should not have to go to maternity and child facility in Hyderabad city. It should be available right at their doorsteps, the same quality, the same things. Okay, so that is ensured through appropriate technology. So I showed you some examples. If a child is suffering from dehydration, rather than running to the shops and running to the hospitals for IV fluid, homemade ORS can be started. And how it is a very simple technology of mixing 5 cupfuls of sugar and 1 spoon of salt in clean water, 1 liter of clean water, and it can be fed to the child, and dehydration can be prevented. Similarly, in areas where electricity was a problem, and syringes and needles could not be autoclaved. Other surgical equipment could not be sterilized because electricity was not there and autoclaves were not working or sterilizers were not working. The concept of pressure cooker autoclave, okay, steaming all the instruments under high pressure, because autoclave also works on the same principle. So this was used, and sterilization and autoclaving of equipments for use and reuse was achieved. So these are some of the examples. Similarly, we have other examples also, like prevention of hypothermia by wrapping a newborn baby in a polythene paper, okay, because the concept of hypothermia is that heat is lost from the body and it should be preserved as much as possible. So wherever that light therapy to keep the child warm, it is not available, you just wrap the child in polythene, okay, of course keeping the mouth and airways open so that it can breathe, and heat loss will be totally prevented. So this was one of the innovations, I would say innovations, which was demonstrated by an Indian doctor. So the focus of all these services, equitable distribution, intersectoral coordination, or community participation, or use of appropriate technology. So focus of all these principles is entirely on prevention of diseases, okay, prevention of infant mortality, prevention of maternal mortality. So there, so that is why in any of the component you don't see that the focus is on cure, okay. Always you see that the background behind all the principles is prevent, prevent, prevent. So health services should not only be curative, but they should also promote health and healthy lifestyles with emphasis on prevention. So that is the mainstay of principles in primary healthcare. Now, these are some of the healthcare systems which operate in India. And at the primary healthcare level, we have village level, subcenter level, and primary health center level if we take the bottom up approach. So at the village level, we have local guides that can be trained, we have village health guides that can be trained. We also have a major contribution from the ICDS scheme and the NRHM scheme in the form of ASHA. So you can describe what the village health guides are, what are their duties. They have simple duties like first aid, maternal child health, family planning, health education, sanitation, medical care for common illnesses according to a given manual. So they don't apply their own minds, they operate according to a manual, and then they refer the patients. Local guides are responsible for maternal and child health care for safe deliveries. So they can be picked up, they can be trained. Their training period is for a period of 30 working days, and they are trained either in a PHC or a subcenter or an MCH center for 2 days in a week for a total of 30 days. And at the end of during the training, they are expected to conduct at least 2 deliveries under guidance and supervision from the ANM or health assistant female, and at the end, they are given a certificate and a safe delivery kit so that they can go back to the village and they can conduct the deliveries. Then there is the ICDS service. Beneficiaries are nursing mothers, pregnant women, other women in the age of 15 to 45 years, that is the reproductive age group, children below 6 years, that is in their pre-education, pre-formal education years, as well as adolescent girls. So along with village health guides, Anganwadi workers are also the community's primary link with the health services and all other services for young children. What are the roles of these Anganwadi workers? They perform health checkups, they do immunization, they do supplementary nutrition, they provide supplementary nutrition for pregnant women and adolescent girls, lactating women, and children in these age groups, in less than 6 year age group. They also provide health education, they provide non formal pre school education, which is targeted towards early childhood development. So this is very important for holistic development, brain development, cognitive development in preschool years. Then we also have the ASHA. You know what the ASHA is. The requirements are that she should be a resident of the village. She can be a married or a widow or a divorced woman, preferably in the age group of 25 to 45 years with formal education up to 8th class. So their duties are to counsel women, to facilitate access to various health services. That is why for most of the delivery services it is said that she will be incentivized whenever she travels with the woman to the healthcare facility. So she provides moral and emotional support as well as technical support also, uh, up to the point to which she is trained. She can provide primary medical care again according to a manual, or she is a depot holder for essential provisions. She informs about birth, death, unusual health problems. So she helps to maintain a health registry and also promotes the construction of household toilets, which is again a motivational work. One of the components of or elements of primary healthcare was ensuring water supply and sanitation, so she works towards these directions also. Now, at the subcenter level, which is the peripheral outpost of the health system in rural areas, it is the first formal center at the community and in the grassroots level. So the functions at subcenter which can be performed by the ANM independently are immunization, antenatal, natal and postnatal care, prevention of childhood diseases through immunization, family planning services, elementary drugs can be given up to the level to which they are trained, and national and family welfare programs are also delivered at the point of subcenter. Now, subcenters have been categorized into type A and type B under the National Health Mission. So these descriptions are given in your books. Okay, and these are some of the minimum requirements. Now there is a lot of talk about quality, ensuring quality at all the primary health center levels. So even for subcenter, the IPHS guidelines have mentioned some quality parameters, like they should be at least providing maternal health care, child health care, family planning, contraception, counseling, adolescent health care, assistance to school health services, water quality monitoring, promotion of sanitation, field visits by appropriate health worker for disease surveillance and family welfare services, community need assessment, curative services for minor ailments, to organize village health and nutrition day at least once in a month, then training of traditional birth attendants and ashas, coordinate services of Anganwadi workers, ashas, village health and sanitation committee, as well as implement national health programs. So these are at least these all revolve around the elements of primary healthcare, and it is absolutely important now that subcenter should address at least these many elements, which are which are derived from the elements of primary health care. Now, when we look at the primary health center, this is the first interface between a qualified doctor and the sick community. So, all the patients who are referred from sub-centers or patients may go independently also. There are two types of PHCs, type A, type B. PHC type A is with a delivery load of less than 20 deliveries, and type B is with a delivery load of more than 20. So, again, IPHS guidelines have laid the criteria similar to the sub-centers. Okay, these also revolve around the elements of primary health care. Okay, then these are some of the guidelines which are laid under the National Urban Health Mission for urban PHCs. So you may remember them, you may not remember them, but this is what a urban PHC looks like. And finally, we talk about the constraints in the primary healthcare delivery. We are saying that so much population is catered, the elements are strong, the principles and foundation is strong, but overall, it has been reported that many primary healthcare centers are failing because tertiary centers are overburdened. Okay, so the whole objective of primary healthcare is not very strongly grounded in the minds of the people. Study done in 2016 showed that subcenters were 20% short of human resources. In primary and community health centers, there was 22% and 30% shortage, respectively. okay, of human resources. So people were not in place. Then when they looked at the structure, basic infrastructure, they showed that 29% of the subcenters did not have water supply, 26% lacked electricity supply, 11% did not have all weather roads which connected very well to the subcenters. So these are some of the constraints. So we talked about access, we talked about manpower, we talked about the basic services, but these are mostly lacking in many of the, almost one fourth of the primary health centers in the country. So these are some of the constraint: manpower constraint, infrastructural constraints. Okay, then number of beds are specified, paramedical staff is specified, but you see the bottom point: 63% of the primary health centers did not have an operation theater, 29% lacked a labor room. Now you can imagine that if 29% or 30% of these primary health centers do not have a labor room, where are they expected to conduct the delivery services for ensuring safe maternal and child health? Okay, so this objective does not get fulfilled then if a working labor room is not present. Community health centers were short of specialists, okay, to the tune of 81%. So they did not have specialists, whereas that is the first interface between community and specialist care. So you see there is lacking manpower everywhere in the primary healthcare system, which is the main constraint so far, which has been brought out by various studies from time to time. So that brings us to the end. What you have to read yourself is what are the roles and responsibilities of medical officer, ANM, health worker, health assistant, how vital events are recorded and reported, and what records are maintained by ANM and how they are reported to the PHC. All these may be short notes, these may be Viva questions, these may come as a part of a long question also. If there are any other questions related to primary healthcare, please email me or WhatsApp me so that I can answer them. Thank you very much. Happy reading. Next class we will take up another important topic. So you can mail me if there is any topic that you want me to cover specifically. You are not clear about it, so please email me. We still have a couple of classes left this month, so we can cover those topics which are important but not very clear to you. Thank you.